So more than 20 grams of iron over 2 years, whereas the normal total body iron is 3 to 4 grams. Now, iron overload in MDS, as measured by serum ferritin levels, is clearly associated with a decreased likelihood of survival, as shown, for instance, by the Italian group in Pavia. As you can see here, there is, above a serum ferritin threshold of 1,000, a clear dose-dependent impact on overall survival with increasing serum ferritin levels. So, isn't that irrefutable evidence that iron overload is bad for MDS patients and must urgently be treated with iron chelation therapy? Well, let us not jump to conclusions, because the data might be interpreted just the other way around. Higher serum ferritin levels simply reflect more severe bone marrow disease and more severe and a stricter transfusion requirement. Therefore, more severe bone marrow disease may be responsible for the higher ferritin levels as well as the shortened survival. But again, we have to be very careful, because Malkovati and colleagues also showed that serum ferritin is an independent prognostic factor in MDS. Even if transfusion dependency is considered on multivariate analysis by including the number of blood transfusions per month, even under these transfusion-adjusted conditions, we see that there's a 30% greater risk of death evident for every 500 microgram per liter increase in serum ferritin above the 1,000 microgram per liter threshold. And very similar data have been obtained in Spain in a large multi-center retrospective analysis, which showed that a serum ferritin level above 1,000 has a drastic impact on overall survival and leukemia-free survival, very similar to the drastic impact of transfusion dependency on overall survival and leukemia-free survival. And again, the Spanish colleagues also performed multivariate analysis, and they showed that there is an independent prognostic impact of the development of iron overload. And they showed that it is independent because the prognostic impact was independent of the WPSS score, which already includes transfusion dependency. So the situation might be a bit complicated, but I think the whole situation can be depicted like this. Certainly, transfusion dependency is correlated with shortened survival in MDS patients because it reflects severe bone marrow disease, with all its possible complications like infections, bleeding, and the detrimental effects of chronic anemia. In addition, however, transfusion dependency causes iron overload, thereby creating a new medical problem, which has its own negative impact on overall survival. And the relative weight of these two risk factors may vary considerably between different MDS patients. Just consider a patient with sideroblastic anemia. Such a patient will probably not die from infections or bleeding. Instead, transfusional iron overload may become a problem over time. On the other hand, consider a patient with RAEB. Such a patient may have a similar transfusion requirement, but will probably not have the time to develop clinical complications of iron overload because severe bone marrow disease is the overriding prognostic factor. Now, the severity of iron overload is usually assessed by measuring serum ferritin. And serum ferritin is sometimes accused as not being a very exact, not being a very reliable representation of iron overload. I readily acknowledge that there are many inflammatory conditions that can influence serum ferritin levels. And such inflammatory conditions may be more frequent in patients with more severe bone marrow disease. So serum ferritin levels, elevated serum ferritin levels, may be an indicator of severe bone marrow disease. But then we would expect a correlation between serum ferritin levels and advanced types of MDS. Is that the case? Not really. We looked at patients in our Düsseldorf MDS registry, and we found that patients with advanced types of MDS, higher risk MDS, have median serum ferritin levels that are clearly lower than median serum ferritin levels in patients with lower risk MDS. And irrespective of whether the patients are transfusion dependent or not. And the same is true for the percentage of patients with a serum ferritin above 1,000. This proportion is also smaller in higher risk patients than in lower risk patients. So you simply cannot call serum ferritin a marker of more severe bone marrow disease. It is not. It is mainly a marker of iron overload. And this view is supported by this recent study from Italy, looking at the prognostic impact of pre-transplantation transfusion history and secondary iron overload in patients with MDS undergoing allotransplantation. And in this study, the graded impact of transfusion burden on cumulative survival and on non-relapse mortality looks very similar to the graded impact of serum ferritin on overall survival and non-relapse mortality. And the accompanying editorial to this paper pointed out that this report strengthens the association between transfusional iron overload and impaired survival for MDS patients undergoing allotransplantation. And it also documents that elevated serum ferritin levels are strongly correlated with the number of red blood cell units transfused, that is, the magnitude of iron loading. Therefore, I think that we can say with confidence that serum ferritin is a suitable indicator of transfusional iron overload. And several studies have now shown it to be an independent prognostic factor. So, if iron overload shortens the patient's survival, how does it do that? Well, we all know that patients with beta thalassemia major can die from transfusional iron overload because they can go into heart failure. And we also know that patients with hereditary hemochromatosis can die from iron-related liver cirrhosis and liver cancer. But quite honestly, we don't see MDS patients die from liver cirrhosis. What about diabetes and cardiac problems? Well, there has been a large retrospective study in a huge American Medicare database conducted by Stephen Goldberg and colleagues. And they found that transfused MDS patients have a higher prevalence of cardiac events, diabetes, dyspnea, and hepatic and infectious diseases than non-transfused MDS patients. And all these complications were more frequent in MDS patients than in an age comparable group of patients. And the increased incidence of infections in iron-overloaded, transfusion-dependent patients was also observed by Dayani and colleagues, who found that cardiac failure and infections are the most common causes of death in lower-risk MDS. And the increased rate of infections may not only be due to neutropenia and granulocyte dysfunction, it may at least partly be attributable to iron overload, because increased availability of iron in iron-overloaded states provides a nutrient for bacterial and fungal growth, increasing the rate of infections. And our Italian colleagues observed the same thing, namely that cardiac failure and infections are the most common causes of death in non-leukemic MDS patients, and they also observed that cardiac failure was significantly more frequent in transfused patients, probably because of iron overload. And Japanese colleagues observed that MDS patients dying from cardiac or hepatic failure had received more than twice the number of blood transfusions than MDS patients dying from other causes.